Hey everyone, this is Dr. Medicine Alex, and in today's video we'll be discussing about Behcet's disease. So it is a type of neutrophilic dermatosis, and in the forthcoming videos we'll be discussing about a few of the neutrophilic dermatosis. So Behcet's disease all in all is an autoinflammatory systemic vasculitis of unknown etiology. So it is also called as Behcet's syndrome or Silk Road disease or malignant aphthosis, and it is commonly seen in the age groups of 20 to 35 years, and males are more likely to be affected. Coming to prevalence, it is seen in countries such as Turkey, Middle Eastern countries, Japan, and Mediterranean countries. Also, one of the reasons why it is called as Silk Road disease because these countries they correspond to the old Silk Road where the ancient trading route stretched. So that is why the another name for Behcet's disease is also the Silk Road disease. Coming to etiopathogenesis, a strong genetic association with HLA-B51 gene is known, and some microbial agents such as Staphylococcus aureus, H. pylori, HSP1, hepatitis, and parvovirus B19 have also been associated. Coming to the actual etiopathogenesis, it is thought to be a type of molecular mimicry by various environmental factors and microbial agents which kind of trigger an autoimmune response. All in all, there is going to be a Th1 activation with circulatory immune complex deposition, as well as the release of pro-inflammatory cytokines such as IL-1, IL-8, IL-12, TNF, alpha. Also, there is going to be neutrophilic dysregulation, hence it is a neutrophilic dermatosis, and also there is going to be endothelial dysfunction. Coming to clinical features, so this is a classical triad of recurrent oral ulcers, recurrent genital ulcers, and recurrent ocular lesions. So the recurrent oral ulcerations, they are the earliest manifestations and they are the most frequent manifestations. So the aphthous ulcers, they can be minor, major or herpetiform. The minor ulcers, they are of less than 10 mm diameter and they are shallow with a fibrinous base. They also have an erythematous halo and they heal without scarring. Whereas the major ulcers, they are larger, they are more than 10 mm in size and they heal with scarring. Whereas the herpetiform ulcers, as the name suggests, they are going to be grouped, they are going to be numerous and they become confluent. So these ulcerations, they can be seen anywhere in the oral cavity, but they mostly occur on the tongue, the lips, the gingiva and the buccal mucosa. Coming to the recurrent genital ulcers, so similar to the oral ulcers, they have a similar morphology and they are a bit larger and they are more persistent and as well as they heal with scarring. And in males, they occur over the scrotum and the penis, whereas in females, they are seen commonly over the labia majora. Coming to the ocular involvement, so again, males are more commonly seen with ocular involvement and it presents as a chronic relapsing uveitis. Both the anterior and posterior type of uveitis can be seen and there can also be hypopyon formation. Coming to other manifestations, so the cutaneous lesions can be seen in the form of pseudofolliculitis, erythema nodosum and acneiform lesions. So the pathology test is going to be positive. Nothing but a needle prick or a needle stick or intradermal injection of the saline causes a papillopustule at the site of trauma and it is seen within 24 to 48 hours. And this generally represents that the disease is in its active stage. Joint manifestations occur in the form of synovitis and non-erosive mono or oligoarthritis, and the vascular manifestations are seen in the form of primary systemic vasculitis, and both arteries and veins are affected, and superficial migratory thrombophlebitis is also seen. Then there is also GI involvement with the segmental mucosal ulcerations, and CNS involvement is seen in the form of meningoencephalitis, paresis, headache, and seizures. Renal involvement in the form of glomerular nephritis and pulmonary involvement in the form of hemoptysis and pulmonary artery aneurysms are seen. So basically, since Behcet's disease is a systemic vasculitis, all the systems are affected. Coming to diagnosis, so the 6 criteria that are kind of the standard for diagnosis of Behcet's disease are the oral aphthosis, genital aphthosis, ocular manifestations, skin manifestations and pathology test as well as vascular manifestations. So the international study group has given a criteria where the oral aphthosis is the most important criteria that should be present along with any of the other mentioned 2 criteria. Then the international criteria for Behcet's disease ICBD also has given a point system where it grades the genital aphthosis and the ocular manifestations with 2 points, whereas the rest of the manifestations they get a 1 point each. On histopathological examination, leukocytoclastic vasculitis is seen with fibrinoid necrosis of the vessel wall as well as tissue necrosis. And in older lesions, we can also see like the lymphocytic or granulomatous infiltration as well. Lab investigations are to be done in order to know the disease activity as well as to rule out any other organelle involvement. So on complete blood picture, we'll see increased total leukocyte count as well as increasing ESR and CRP levels. There is also increased levels of beta-2 microglobulin and serum myeloperoxidase. And to rule out other autoimmune diseases, we also have to do rheumatoid arthritis RA factor as well as ANA and ANCA profile, which are negative in case of Behcet's disease. And liver function tests, urine analysis, CSF analysis with the CT and MRI imaging, then barium studies and endoscopy and chest sciagram and synovial fluid cytology are necessary for organelle involvement detection. Coming to management, so local management in the form of triamcinolone acetonide oral paste and mouthwashes for the oral aphthosis, and also chlorhexidine, triclosan or tetracycline mouthwashes, along with 2% lidocaine or 0.5 to 1% tetracaine are necessary for oral aphthosis in case of pain. Topical corticosteroids are effective in case of genital ulcers. And systemic treatment is given when the lesions are non-responsive to topical therapy, or if the lesions are chronic, or if they are recurrent. And systemic drugs in the form of colchicine, either 0.5 or 0.6 mg BD, depending upon the response, or corticosteroids starting at a dose of like 0.5 to 1 mg of oral prednisolone, or cyclosporin, azathioprine, cyclophosphamide drugs, and IL-1 blockers such as anakinra, and other biologics such as TNF-alpha inhibitors such as etanercept or infliximab can be useful. Thank you. Subscribe for more.